session and the slides will be made available after the session. So if you don't want to be on the recording, you won't miss out. By all means, like I said, use the chat for any questions, and there's a few people have already done, which is fantastic. If you could introduce yourselves quickly and just a little bit about you and your role in the chat, that would be great. There are no future sessions to tell you about, apart from perhaps if you have missed any and you want to engage in them firsthand, we will be running a second cohort starting in January next year. The dates will be available pretty soon, I think. With that, the recording is started. I'm all done, so I will hand you over to Lisa, who will be running today's session. Lisa, over to you.
Thanks, Phil. Hi, everyone. I'm Lisa Cummins. I'm a lead health economist at the Health Economics Unit. My colleague Heather as well was going to be running this session with me today, but she's unable to, unfortunately. But I've included her here because she has done some background work as well to prepare for today, and she may be involved in future sessions as well. If you don't know much about the Health Economics Unit, we are a team of health economists, analysts, data scientists and data engineers working across the NHS is kind of at national level and at organisational level, but we also work with charities and others as well. I guess there's kind of three main work streams that we cover. The first is around health economics and economic evaluation. The second is around population health management. And then the third is around kind of data science and advanced analytics. And our aim really as an organisation is to deliver impactful insights to power the future of health and care delivery. A bit about me. I was an analyst, or initially, that was what I trained in. And while I was working as an analyst, I upskilled in health economics, and then I transitioned into health economics. So today, what we're going to cover is a conceptual need for demand and for need, a conceptual model of need, demand and supply. So that'll be kind of the first half of the day of the session, of the 2-hour session, and the second half will focus more on equity in health and health inequalities. What would be useful to do at the end of the session, and if you have time, either in the chat or in the feedback form, is just have a think about whether or not I have jam-packed too much into this 2-hour session, which I think I have, and I think we'll need to tweak it going forward. Even part of me is thinking about separating the two distinct topics, so need, demand and supply, and equity into 2 separate sessions. So it would be good to know if you think both are useful to you in your role, or just even if you're just generally interested in it, or if you think actually no, that really wasn't relevant. Or alternatively, if you would have liked me to delve deeper into one area over another, that would just be really helpful for future planning for these sessions. Right, I will jump in. So in terms of need, demand and supply in healthcare, the reason why I've included this session really is because ICSs and other ICSs, so integrated care boards, working in partnership as well with other organisations, are responsible for distributing resources more efficiently and equitably across the population. So I felt that an understanding of need, demand and supply and different concepts relating to these in health economics would be useful to you and others in your roles, as it's really important really around making decisions about resource allocation. Another thing is, if you have any questions or comments, or if I'm going too fast, just let me know and I'll pause and I can take questions, whatever. I can't quite see everyone, Phil, so do give me a shout if someone does ask a question. So what I'm going to cover, as I said, are key concepts in health economics relating to need, demand and supply. And then I'm going to discuss the interconnection kind of between these three areas, and have a discussion around and kind of place them really in the context of reasons for unmet need and other things like need-based demand and unnecessary demand, and also appropriate use of healthcare. This model itself comes from work that was published by Rodriguez et al. In 2021, I think. And what I've done is just kind of adapted it here. I've simplified it in parts, but I'll share a link to the paper for anybody who's interested in it. So I'm just going to start off quite basic when we think about need in economics. So need is essential for anything really that you can't live without. It's essential for survival. And this is often compared to a want. So a want is something we desire, something we might want to consume. So you can see there on the left, the things that are essential for survival are food, for example, but other things are like shelter, basically things that we can't live without. But a desire is then something that we might want or somebody else might want. So if you have an interest in video games or something like that. I'm also going to deduce here just the concept of need from the perspective of health and social care, because on the next slide I'm going to introduce how need is defined in health economics. So just thought this would be useful to really see the kind of distinction between those. So in health and social care, a healthcare need is related to the treatment, control, management or prevention of a disease, injury, illness or disability. And it also includes the kind of care or aftercare that a person with these needs might require. And this is, on the other hand, then we've got a social care need. And these are just to note as well definitions that I've taken from the National Framework for NHS Continuing Care, Healthcare, and NHS funded nursing care documents that I've included a link here. So social care need is a need arising from or related to a physical or mental impairment or illness, which results in an individual being unable to achieve two or more day-to-day activities such as feeding, washing and dressing, and any other thing that we would ordinarily be able to do in our day-to-day lives. In health economics, a need is defined slightly differently. So it could be defined as the capacity to benefit from healthcare or social care. So the capacity to benefit part, I think, is the kind of tricky part, but also the important part here. And if we could understand it in a way that you're said to have a need if a treatment, for example, exists that would provide you with an improvement in health. And I'll kind of get into this in a bit more in a moment. But does anyone have any questions around that?
Annie's put something up, Lisa, saying that those definitions should never have been separated as they're so interdependable.
But if we don't, then we'll always be limited.
Thanks, Annie. Is it these ones, the healthcare need and social care need?
Sorry, has somebody got their, sorry to interrupt, somebody got their microphone on?
Yeah, I can mute them.
Brilliant.
Yeah. Annie, I totally take your point. I just pulled out these definitions from this guidance just for the purpose really of illustrating the difference between understanding need from a kind of general perspective and a health economic perspective. Okay.
Oh, Annie's writing something in the chat.
Cool. Thanks, Annie. Cool.
Did you see it? Cool.
Yeah, thanks, Annie. Cool. So, I've got a question here as well. So it'd be interesting to hear your thoughts on this about whether wants differ from needs when it comes to healthcare. Just in the interest of time, I might not have a discussion around this and I'll just give you the answer because I've got better questions coming up I think we should spend more time on. But the key thing really here is that not all wants are needs and not all needs are wants. So for example, you might need to see a dentist, but you might have a fear which might then kind of inhibit you from going to actually seek that care. So you have a need, but you don't want to go because you don't feel comfortable going. So what I'm going to focus on next, very briefly, is definitions of needs that are met or unmet. So from a health economic perspective, a need is met when effective, cost-effective, or appropriate treatment is provided. The appropriate here is included because there are some, for example, treatments or models of care or ways of working that might not have been proven to be effective or cost-effective, but might be used in different settings. So an example of this might be a new digital technology that hasn't yet been proved or demonstrated to be cost-effective, but it's being trialed or piloted in a trust or organization. And it might be that the lead clinician, for example, might feel that there is a clinical need for this and they feel it's safe enough for use. So then it would be deemed to be appropriate. And then on the other hand, a need that is unmet is considered to be one that's when there's a shortfall in services required to meet the needs of a population. We're going to go into this in a bit more detail anyway in a moment and have a discussion around different reasons for unmet need and stuff like that. So the next concept after need to think about is demand. So demand for healthcare is a derived demand arising from the demand for good health. This is a bit of a kind of maybe difficult to understand on initial reading, but I'll try and explain it so that it's more intuitive. So if we have an ordinary demand for any good of service, we usually demand that good for a reason. So if we need food, for example, if we demand food, we need that for nourishment so that we're healthy and that we have enough food to survive. Or if we demand another good, for example, video games. So somebody might get enjoyment from this, or maybe if you're a parent and your child is playing video games all the time, then maybe you won't get enjoyment, you might get frustration, for example. Frustrated, sorry. But when it comes to demand for healthcare, we demand healthcare to improve our health because we can't just buy good health, for example. It's not something for trade that can be traded. So if I'm sick, for example, and Phil is full and fit, fighting fit, for example, I can ask Phil to give me some of his health. I need to maybe, if I've got a cough or a cold, need to take some medicine, and by demanding that medication, I then hopefully would have an improvement in health. Does anyone have any questions on that, or does that sound okay? Got some people writing in the chat, so I'll just give them a minute. Thanks, Mark. Good to have you here again, Mark. Cool.
I couldn't stop myself.
Perfect. I'll keep going then and take silence as that it's understood or explained. Another second point just to note on this slide is that because healthcare in the UK is free at the point of use, demand is generally higher than it would be, for example, if somebody had to pay for it. And the reason for this really is, and if you look in countries like America, where you don't have universal healthcare, even though they do have a need for care, they can't afford it. So then demand is lower because demand is affected by the price of care. So it's less of a thing to consider here, but also just something to note. And then supply is an easier concept, and it's basically the level and mix of services, treatments provided by a healthcare system. And in England, it's especially constrained by budget and scarce resources. So each ICS local authority only has a certain budget that they can work within really each financial year, and that impacts what they can deliver. And then another massive issue is scarce resourcing, and the biggest one really at the moment would be staffing. And the second point to note is that it can vary over time and across areas as well. So you can have, if anyone was on a previous session, we talked about how NICE can recommend treatments, but then an ICS is really responsible for providing those treatments in their area. So it kind of just depends then on what's available. In terms, so now what I'm going to do is talk about, I guess, key things that we're all kind of familiar in a day job around, like unmet need. We hear about things like unnecessary demand or appropriate use of healthcare. And I'm going to use this conceptual model just to delve into these in a bit more detail. This is just a quick recap on what I went through. So need is defined as the capacity to benefit from healthcare or social care. I'm sorry to local authority colleagues that I haven't, this is healthcare focused, but I can tweak the slides for the next session and make sure it's health and social care focused. Demand, then, as I said, is a derived demand arising from the need to improve one's health. And supply is the mix of services and treatments that are provided in an area. So the first thing I'm going to cover is need-based versus unnecessary demand. And what you can see in the Venn diagram, each component has a number. And what I'll do is just kind of discuss what these concepts kind of mean and which areas they cover. So need-based demand covers area 2 and 5. And this is demand that is deemed to be appropriate according to an individual's needs. So a person has a need and they demand healthcare for it. That's how it will be defined from a health economic perspective based on this model. On the other hand, unnecessary demand is demand that is not based on healthcare need. And in some cases, care is provided to meet this demand, even though it's not required. Can anyone think of any examples of what type of demand might be considered unnecessary, something that might be provided, even though it's not necessarily needed? Feel free to pop your thoughts in the chat or turn up your mic and shout it out.
Mark's having a go. If anybody else feels like just shouting out, please do.
Please do.
We are a friendly bunch. We won't bite, shout, or do anything negative. It's just nice to hear everybody getting stuck in.
Sorry, what was the question?
It was whether or not anyone can think of any example of care when there is a demand but not necessarily a need, but care is provided. So I can give an example and then that might prompt others to think. So an example. Sorry?
Yeah, I think I can give an example. So you may demand something, but you don't need it. For example, maybe plastic surgery, for example.
Yeah, that's a good example.
So you could demand it. You don't need it. The healthcare system may not deem that to be necessary for your health as part of the population, and therefore will not be buying that service for you, will not be providing that service for you. If you want to turn that into a demand, then you can pay for it privately.
Yeah, that's a really good example. Thank you.
We've got a few answers in the chat. So Mark says antibiotics for viral illnesses, false positive results. Shandan, sorry if I mispronounced anybody's name, I do apologise now. Thinks maybe they missed a slide about unmet need.
We're going to come on to that. We're going to go
Brill.
into that in a lot more detail.
There we go. Hopefully that answers the question. You haven't missed a slide. It's yet to come. So stay tuned.
Thank you.
You're very welcome. And he's asked, does preventative public health work fall into this category?
That doesn't fall into this category because the idea is that that would be there to meet an actual need that exists. So you're kind of giving away a question I have later, but that would actually fall under 4. So there's a need and something supplied to address it, but there's not a demand for it yet. So somebody might, like cancer screening could be a good example of that. If or like targeted interventions to address obesity and stuff like that as well, which could then turn into a future demand for care.
Quite an interesting one as well from Annie here about perceptions being different. So many people would have plastic surgery, which meets a mental health need rather than, say, a physical or aesthetic need.
That's a really good point, Annie, because if there is a need then and it's provided, it would fall under either of these 2 or 5. Or it would fall under 5, sorry, because it would be provided and there is a need for it. And another example of 6 that's in the news definitely at the moment is delayed discharges. So somebody's in hospital, they're ready to be discharged, but there's nowhere for them to go. For example, they might be waiting on social care or anything like that. So they're taking up a bed basically, and they're demanding care and it's being supplied. I'm going to move us on, but thanks everyone for contributing. Now, the next one we're going to cover is met versus unmet need. This is actually just a copy of this earlier slide, but what I do highlight here as well the areas where so a need that is met covers areas 4 and 5, whereby a need that is unmet falls into areas 1 or 2. I think that a met need is pretty straightforward, so I'm gonna leave that for now, and we're going to go focus a bit more on different reasons for unmet need. And in the paper, the authors kind of from different, they kind of bring together previous research on unmet need and economics and stuff, and they come up with 5 different reasons for unmet need. So the first 2 are said to fall under fall into area 1. And the first is unperceived. So this is when a person may not realise they're unwell, but they are in need of care. The second type of unmet need is chosen. So this is when a person has a healthcare need, but they choose not to obtain treatment. And then the last 3 are said to fall into this area here, area 2. So you've got unchosen, which basically captures anyone that has a need, but it's unmet due to factors outside of their control. The fourth one, clinician validated, is when a person perceives a need and accesses care, but they don't consider that care to be appropriate. Or actually, sorry, no, that's slightly incorrect. I'll just repeat that again. So that's when a person perceives they have a need and accesses care that is not considered appropriate. So this is when, like, a person might Google, for example, a health condition, treat themselves, and then go to the doctor and say, oh, I have this treatment, and the doctor might say, oh no, that's not really appropriate, for example. A subjective unmet expectation is when a person receives care, but they don't believe that their need has been met. But in this case, the whoever is treating them would believe that their treatment has been met. So I'm going to do a little exercise, which I hope will help with the kind of understanding the different, understanding some different examples of these different types of unmet need. So what I've got are just 5 examples under A, B, C, D, and E. And what I'd like you to do is match each reason for unmet need to each example. And I'll give you a few minutes to do that. But if you want to pop your answers in the chat or shout them out, you can do that too. But I'll give you 1 or 2 minutes to do that.
I'm definitely getting a countdown timer for next year. Mark's jumped straight in there. D, unperceived.
I didn't quite mean to do that, actually.
What were you still mid-type?
I was going to bunch up all my answers together and I completely got it wrong. Sorry.
That's all right. Anybody else? Anybody want to shout out any answers? Or, you know, good point to have a discussion. Costanza, E, chosen. Yeah, I'd be that too. I don't like dentists. Hannah says A is unchosen. Ooh. And E is chosen. Flying through them now. A, unchosen. B, clinician validated. A, unchosen. C, subjective, unmet expectation. C, subjective.
Ooh, I think we've covered most of them. I think almost all. I think they're all right, actually. Thanks, everyone.
That's fantastic.
Does anyone have any questions? I'll just go to the next slide and it shows the correct answers. Any questions? Oh yeah, Mark, you've got your hand up.
Yeah, just to question how this relates to value. So sometimes we treat patients because it's easier to treat them than not treat them, even if we don't necessarily think that they need the treatment. Sometimes you just end up doing it because it closes the consultation. You know, you give them an outpatient appointment, or you refer them on to somebody, or you give them antibiotics, or whatever it is. So I don't know how these two things kind of align between what's the value of treating need that isn't really need? It's only a want.
Yeah, I think that's a really good point. And one way we've been using this model is in a demand and capacity project that we're doing, and to really kind of help us understand what are we trying to measure, what can we measure, and this is specifically for treatment for people experiencing gambling harm. So what are the needs of the population? What referrals are they getting? Where are they being referred to? Are they completing the referrals? And then trying to understand map out the actual patient pathway or the service user pathway, and then see where those discrepancies are. And then it's allowing us to identify the right metrics and quantify the right things. So I hope that kind of helps answer your question, but I guess by using the full model, it can help kind of tease out those things. What is appropriate, what's inappropriate, what do we need to measure? Good, thanks.
Sandra's, sorry.
Okay.
I think I just cut somebody off there. I do apologise. I was just going to say Sandra's got a comment about social prescribing, and whether that's picked up some of these scenarios.
Yeah, social prescribing is a big one, and it's like an area I'm only slightly familiar with. I do know that there's gaps in the evidence or the effectiveness of different social prescribing treatments, because it's quite new. And just by the nature of the way the services are delivered, it's difficult to kind of quantify those effects. But if you kind of go back to the definitions used in this paper, so long as the treatment is effective or appropriate, and it works, then I guess it would be considered a met need. But if maybe it's something that's a cheaper alternative to maybe a more kind of comprehensive program of care for somebody with different level of kind of mental or physical health needs, then maybe it's not appropriate. But it's a good question that I don't have the answer to, I'm afraid. I'm going to move us on then, and cover appropriate use of healthcare, which we kind of talked about. So, and actually there's what I noticed as well is when I kind of really got into the paper and started teasing things out, there's kind of overlap as well in some of the definitions that they've used. So they consider appropriate use to be the same as met need. So appropriate use is considered appropriate use occurs when the treatment or service that is being provided to those who need it. Whereas inappropriate use is using a service despite having no need for it at all. And that will be area 6, which we kind of talked about earlier as well, when we were covering unnecessary demand. So you've got unnecessary demand and inappropriate use are both kind of can we kind of use those areas within the model. And this is kind of going back to what I was talking about for how we're using it in our work for building a demand and capacity model, is you can really start to pull out those kind of differences of something that's an inappropriate use or unnecessary demand. I have a question here around whether or not anyone can think of examples of inappropriate use, but I think we've kind of covered that mostly. Does anyone have any questions on any of any of on this slide?
I would say carry on, I think.
Yep. Thanks, Bill. The next slide, I've got unused supply. So that's area 7. So that's the one area that we haven't looked at yet. So unused supply can happen because of excess supply or surplus capacity, and also it can happen when supply doesn't address the need or demand, but has the potential to do so. I guess the first question I have is, can anyone provide an example of when supply might be unused? You want to shout out or pop out your thoughts in the chat?
Oh, Hannah's stolen my thunder. I was going to say vaccinations because it was the only one I think I knew.
That's a good one. So is I think it was like excess PPE, or I think it was beyond use at some point. Maybe I've just muddled that up, but I feel like that was the thing. But yeah, unused vaccinations are a good one. And then excess, another example, maybe when there's surplus capacity, could be when or I guess surplus, well, this is more surplus resources. If in kind of commissioning each year, you might have a budget that you need to spend within 12 months, and you get to kind of like 9 months and you realize, oh, I still have this big chunk of money to spend. But if you don't actually spend it, then your budget will be reduced next year. So you kind of maybe supply additional services that might not necessarily be a need for those at that point in time, which kind of then leads to inefficiencies. And that's kind of linked to the second point as well. Cool. If no one has any questions, I'm going to carry on.
Sorry, there's one from Annie. Would a service that's not reaching its intended target population fall into that? Or is that would be something different, wouldn't it?
Yeah, so think with that. So they're providing care, but they're not necessarily reaching those who need it. Then it could be in 6 or 7. For sure.
There we go.
Yep. Yep.
Brilliant. Hopefully that's answered the question.
Mm-hmm. And DNAs, yeah, that's a good example. Cool. Okay, we're going to move us on. I think we might actually finish on time this time. Cool. In terms of so the authors as well talk about access in the paper, and they define access as getting the right care in the right place at the right time, which is also something I think that they, definitely a quote from the NHS that I've come across a couple of times before. And this is again kind of appropriate use or met need as well, so it kind of covers the same area. And this is just the definition of access again in this paper, and there may be different definitions of access in other literature or other discussions around access for healthcare. But here it's around getting the right care in the right place at the right time. But we know that access is rarely equitable. Sorry, I'm just going to check. Yep. And a good example of this is captured by the inverse care law, which basically states that people who most need healthcare are least likely to receive it. An example of this is from research that's been done pretty recently, I think, and shows that GP practices in the more deprived areas in England are relatively underfunded, underdoctored, and perform less well on a range of quality indicators compared to practices in wealthy areas. So what I'm going to do is have a bit of a short break now before I jump into the next session. But before I do that, does anyone have any questions on that first part of the talk today? Because I probably won't cover need, demand and supply anymore.
Now's your chance, folks.
And then I went, cool.
Yeah, I'm going to take that as the general consensus.
Cool. And I might just ask a follow-up question. Do you think this was interesting? And because I did feel I rushed through it in parts, do you think it would be better to do this over 1 2-hour session in the future? If you want to put a thumbs up in the chat, or I don't know if you can do a thumb. You can probably do a thumb.
No, there's a thumbs up. There's a couple of thumbs up flying up the screen.
Cool. Okay, that's good to know.
Okay, everybody's throwing up a thumbs up by the looks of it.
Will we take a quick break then? If we come back in 10 minutes, and we've got more content to cover in the next hour. So
Okay, so should we say 5 to 3?
Yeah, that's perfect. Get a quick
Brilliant.
break and a cup of tea.
Great.
Thanks,
Everybody have a comfort break, grab a drink, and we will see you in 10 minutes.
Thanks.
Excuse me. Are people starting to come back? Show of hands, maybe. Hello, hi Hannah. Nice to see you.
Hi, you too.
Hi Nina. Brilliant. Just yeah. Great, fantastic. I'm sure Lisa won't be.
I'm here.
Like I said, Lisa won't be long. Looks like everybody's back, so whenever you want.
I will share my screen. Great. And I think I need to go back a bit. Cool. So what I'm going to focus on over this next hour is equity in healthcare. So I'm going to cover kind of key concepts in equity and related concepts like equality, and touch on kind of justice and fairness as well. And then I'm also going to focus on kind of difference between health inequalities and health inequity, and talk a bit about measuring inequalities, but we won't really have a lot of time to delve into that in too much detail. But really the kind of key aim of this session is to kind of just discuss kind of the key different concepts again. So I often find that people use terms interchangeably and when they can mean quite distinct things as well. Again, I would encourage you to ask questions and get involved as well. So what do we mean by equity? Equity is an ethical concept and it has its origins in concepts of social justice and fairness. But because I guess fairness and justice, or I guess what is fair and what is just, can be interpreted differently, a definition is needed so that we can kind of use it in a more practical way when we're trying to understand it a bit better and analyze the differences as well that result in inequity. So what I've used here is the definition by Braverman and Kruskin from their 2002 paper, which kind of discusses equity in detail, and I've shared a link if anyone's interested. But they describe equity as the absence of systematic disparities in health or in the major social determinants of health between social groups who have different levels of underlying social advantage or disadvantage. So what does this mean? So basically means, or kind of the way I like to understand it is that like if a person has a lower level of income or are have a different gender or from a different racial, ethnic or religious group, this shouldn't necessarily mean that their health is further affected. And because health really is important for our well-being and also for overcoming other kind of for then overcoming kind of the different social determinants that determine our health. So if we are sick, we can't work, which affects our income, which can put us at increased risk of different conditions, which can then increase our health. And so it's kind of like this circle, really vicious circle of needing to kind of be healthy so that we can participate in society. I'm going to carry on, but ask questions or ask me to kind of put anything in the chat if you need it. I'm sure you've seen this image before. I'm just going to, it's a nice one kind of to introduce different concepts of inequality and equity and kind of related concepts. So inequality is really about when things are unequal. So here they're talking about unequal access to opportunities. So you can see the kind of tree is there's apples falling from it, and this one person catches it. So they're kind of in the right place at the right time to access that apple. Equality then is around evenly distributing resources or equal distribution of resources. So in this case, they've provided both the boys, I think they're boys anyway, with ladders, but because the tree is curved in one direction, this person here on the right can't, still can't avail of the apples. On this bottom left-hand one, we've got, it depicts equity, and what they've done here, if they've tailored the length of the ladder to the needs of the individual. So they've given them this bigger one so they can now collect apples. And here in this last box, this represents justice. So it's kind of around fixing the system so that everyone has equal access and equal tools as well. So what they've done is effectively straighten the tree so that everyone can access the apples. And why is equity in health important? This is Michael Marmot, who's done lots and lots of research on health equity in England, and he published, I think the Marmot Review 10 years on was published in 2020. But in that report, they talk about how good health is an indication that society is thriving and that economic and social and cultural features of society are working in the best interest of the population. So really, it's important because health, as I already mentioned, is linked to the conditions in which people are born, grow, live, work, and age, and it's affected by inequalities as well. So what we really want to do is try and improve equity and address inequalities by addressing inequalities so that everybody can enjoy a better quality of health and other outcomes as well. We're going to talk a bit about equity and health economics. So in health economics, equity is concerned with how healthcare and resources are distributed. So how health and healthcare is distributed across the population and among groups is important, and also how the financial burden is shared among different groups, which the second point here is probably less relevant to England because we've got free, because healthcare and social care is free. Well, healthcare is free at the point of use. It does actually have implications for social care because that is means tested and you often actually have to pay for that, or your resources, your own resources such as your home may be used as finance to provide social care in later life if you need it. So I have a quick question and you can either shout out or pop your answers in the chat. In healthcare, should everyone be treated the same or should people be treated according to their individual needs?
That one should generate some interesting answers, I think. Individual needs, according to their needs, seems to be the consensus so far. That's Nina, Adele, Aidan, Alan. You said equity. Are you changing your answer, Nina? Hannah, individual needs to attain same outcomes.
I think everyone's hitting the nail on the head there. So really what we want to strive for is equitable treatment and distribution of resources. And I think this captures it nicely here. So on the top, we have got an example of when there's an equal distribution, and on the bottom it's where there's an equitable. So if we provide everybody with a bike to get from A to B with the same bike, some people either can't use it, or for some people it's really difficult for them to use. So it's really not functional or fit for purpose. But if you adapt a bike to the needs of the individual, then everybody can benefit from it. So yes, I would agree with everyone that I think equity is more important over equal treatment in healthcare. Other important concepts in equity in health economics are horizontal equity and vertical equity. Horizontal equity relates to equal treatment of equals, and this is interpreted as kind of how much those with the same level of need have the same level of access. And on the other hand, you might have unequal treatment of unequals. So that's the degree to which those who are unequal, maybe by deprivation status or other characteristics, have unequal access to healthcare. Equity and the establishment of the NHS. So if we think about it, the establishment of the NHS was born out of the need to improve equity in healthcare. Before it was brought into being, there was very little health insurance coverage. There's partial national insurance schemes, only typically for men in manual labour. And services were generally unfairly distributed, with more deprived areas having the lowest access. So the NHS was set up as a service for everyone. It's free at the point of use, comprehensive in terms of coverage, and also had aspirations around improving quality of care and providing care that was based on need and not necessarily ability to pay. Since the establishment of the NHS, there's definitely been considerable improvements in equity in health and social care. But how do you think we're doing today? If you want to shout out or add your thoughts in the chat.
Anybody going to shout out?
I'm going to shout out. Can you hear me?
Fantastic. Yes.
Let me do it. I work in the screening program, a diabetic eye screening program, and I do find that improvements are very slow in terms of equity. There's still a lot of pockets of populations who are still not being reached in respect of a program that's been going for nearly 20 years. So I think that it's still on the equality side, it's accessible in respect of there's different places to go, but in terms of equity, a lot of those places are not reachable or are not suitable, and so there still needs to be a lot of analysis around that. And I think it's because maybe equity is not really understood very well within programs. They understand that it exists, but I don't think it's really very much analysed. I can only speak of my own little program that I'm working for, but that's my observations of that. I think it's a very slow improvement.
Thanks, Adele. That's really good observation and a good example from your work as well. But yeah, I think often what we do is we describe where the inequalities are, but we maybe don't take it the step further then and really are kind of pinpoint who are those populations that need then as well, because you're often being asked to provide a kind of comprehensive service to try and reach the most, but actually you're really reaching those who need it. So yeah. Thanks. Bill, are you going to jump in?
Hannah's dropped a comment in the chat as well. The improvements of recognition in the issue, but issues with data to really understand what needs to be done.
Yeah.
Suppose, yeah, I guess.
I totally agree with that. I've got an example in a while which can kind of show you the limitations of, I guess, building inequalities dashboards.
Sandra says it's getting worse.
Yeah, dentistry for children is a massive issue, but they've added it as a fifth, I think it's the fourth October edition in the new Core 20+ Children and Young People's National Approach that published yesterday. But it's been a priority for a few years. But yeah, I think it's definitely gotten worse with the pandemic. Cool. I think maybe we're all in agreement then that there have been improvements, but things are stalling or kind of not maybe getting to the next level that they need to get to. And this was demonstrated as well in the Marmot review. So just included 2 or 3 slides here, which show that this first one shows that inequalities in life expectancy have increased as the social gradient for life expectancy has become steeper. In addition, life expectancy varies as well by deprivation and region. And here we can see that life expectancy in London has increased more rapidly than elsewhere since 2010. And I think this is especially compared to the Northeast, which has had the slowest rate of improvement in life expectancy over the period. And also it shows that life expectancy varies by deprivation and local area. And this again is from the Marmot review, and it shows the relationship between local authority deprivation and health and life expectancy at birth. And I remember I did an analysis myself in Northeast London a while back, or just did a quick look at kind of comparison of healthy life expectancy, and even in boroughs that are right next door to each other, the difference was like, I can't remember off the top of my head now, maybe it was like 10 years between 2 different boroughs, literally right next door to each other. But just because of the level of deprivation in inner East London compared to outer was so different. So quick one, are people familiar with this model from Dal Green? And I didn't write down the note that I can't remember the other guy, but it's a kind of common one we see. Thank you. Or does anyone want to quickly kind of talk through this? I'll give it a 1 minute and then we can and then I'll ask the question. So basically this just represents how different factors affect our health. So what you have at its core is individual characteristics, so our age or sex and other factors, which could be anything from like our ethnicity or hereditary factors, for example. The next factor that can affect our health is our individual lifestyle. So this could be how much, how active we are, whether we smoke, if we drink alcohol, and our diet and stuff like that. The next factor relates to social and community networks, and this includes any effects that may come from our family or whether social circles. And then what you have on this outer layer is kind of other key determinants, which include things like the quality of our housing, the healthcare service we can access, whether or not we're employed, our level of education, and all these other factors. And then outside of that then are kind of more general socio-economic, cultural and environmental factors, which could be anything from tax system, which is quite topical at the moment, availability of work, and yeah, kind of those are kind of the main factors which can affect our health. And I guess these are kind of complex as well. So, and they can all be kind of related to one another as well. So which factors do you think contribute most to our health out of these? Pop your thoughts in the chat or share it out.
Wouldn't it depend on what factors are actually important to you? Culturally, socially, because I think that's quite a generic answer there, because everyone's different. And I'm just thinking of my own culture, that there's many things and many factors that could affect my health. It could be that I'm very ambitious, want to be going on in my career, but the glass ceiling glass ceiling. So it might not be that I'm not educated. I'm very educated, but maybe my my conditions at work would affect my health in terms of my mental health and so forth and like that. So I'm just thinking, would that make any sort of sense, so to speak, or maybe somebody else could help me?
It does make sense. And on the next slide, I kind of have an image which I'll show in a moment, but it shows the complexity as well and the interaction between these factors. So it's not kind of one single factor that can, like if you were, as you say, like if you could be in employment and then all of a sudden something beyond your control might affect that, which then can affect your health. It might affect your housing. So everything's kind of linked. So this is kind of a little bit of a trick question, I guess. I think one person was typing.
They were, but it stopped. So
I think I'll also just jump in and say, well, as you say, I think obviously they all contribute, but I think lifestyle factors can be one of sort of the largest impacts because they on their own can sort of have such a key impact on people's health. So I'd say that's one of the key ones.
Definitely, thank you. And socioeconomic factors. Cool. Right, I'm going to jump ahead to the next one just so I don't run out of time like I did the last time. Now this is just from maybe I should ask a different question the next time. Sorry, I'm just thinking in my head. I'm thinking out loud when I should be thinking in my head. This is an example from just one study, and it was specifically looking at factors that were affecting COVID outcomes and it's from the United States, but I think it kind of does well to capture that complexity, and as well it just highlights that a good proportion of our health is not directly affected by healthcare, the healthcare that we receive, the clinical care we receive. So they found that 36% was due to individual behavior, 24% was around social circumstances, 22% was associated with genetics and biology, and 11% medical care, and then 7% physical environment or where we live. Any last reflections on social determinants of health and the complexity of different factors that do affect our health?
Yeah, I think that in terms of individual behaviour, that's not very well understood in the healthcare services, such as people's culture or religion. I think we've sort of come to a stagnancy about how people really live and work, because that's becoming more complex every 10 years, so to speak. So I think individual behaviour is not very understood. We've assumed a lot, and I think, delivered services in relation to past information, and yet the populations are changing, people's views are changing. So I think, yeah, I would concur with this. I'd like to look at that a little bit more, but thank you for that.
Good. I have
Hopefully
a link.
That makes sense.
A link in the paper that I can share. It'd be interesting to know, like in where you work or in your area, do you see any differences, even coming out of the pandemic or anything, like when there was a big drive to try and address vaccine uptake, like in taking different approaches to try and reach different groups of the population? I don't know where you work though.
Oh, sorry, is it for me? Sorry.
Yeah, just any.
Oh.
It doesn't have to be COVID or any like.
I think COVID is a good example, because in terms of individual behaviours, as we found with COVID, it wasn't very well understood why people wouldn't want to take it up, and there are, as you said, many complexities to people's lives, such as I said, culture, religion, or even just their own personal convictions, and so those things are more the reasons why people just don't want to do certain things that they might feel that it might be a good idea, but it's not something that they would want to do because there's another conviction that overrides that. Mm-hmm. And I think that's not very well understood, how really important and deep some convictions are, that people would actually do that to the point where even if it means life or death, so to speak. Yeah. So yeah.
It's a difficult one to address for sure. Cool. I'm going to move it on now next to health inequality, health inequity, health inequalities, and how these two concepts are related but distinct. Cool. So health inequity, and this definition is kind of the reverse of health equity, which I've already shared, which is described as the presence of systematic disparities in health between different groups of people arising from the conditions in which they are born, live, work, grow, age, and also differences that might arise because of inequity in power, money, and resources. And again, this is from that Braverman and Gruskin paper, or adapted from it. But a very similar definition is used elsewhere, like in the Marmot Review as well. And then on the other hand, you have health inequalities, and these can be thought of as the actual avoidable, unfair, and systematic disparities in health that exist between different groups of people. So typically they're measurable and observable. So I want to use an example just to introduce or try and add some intuition and difference, explain the difference between these a bit more. I'm going to use an example from type 1 diabetes in children and young people. In diabetes care, HbA1c is a marker of overall diabetes control, but it's also a useful indicator of the risk of diabetes-related complications and early mortality and health. And what you often see is that there are disparities in HbA1c depending on where a person lives and other factors like deprivation and ethnicity. So what I've included here is a table which shows the mean HbA1c level for different groups of children and young people who have their diabetes care recorded in the National Diabetes Audit. So what you can see is, or what the data really demonstrates is this inequality in health between across different ethnicities and across deprivation, and how that varies then. So what you can see is you've got lower rates of HbA1c typically in the least and second least deprived areas for all ethnicities except for children and young people who are Black. So that's quite shocking in itself. But the presence of this disparity then can be considered as an inequity in health. So those living in the most deprived areas and from certain ethnicities, so as I said, those especially who are Black, but also got mixed as well, tend to have poorer outcomes, tend to have higher HbA1cs, and then this can potentially be translated into a higher risk of diabetes-related complications and early mortality. So what I've tried to demonstrate is you have this demonstrate health inequalities, but by the existence of these inequalities, we then have a health inequity. Any questions on that? Sorry if I didn't do a good job of explaining that.
I think it was a good description. Anybody want to join in, or are we okay to move on?
I'll jump ahead then.
Yeah.
So we've kind of talked a lot about highlighting inequalities and not really much about addressing them. So I have a question here. How can healthcare providers reduce health inequalities and address inequity in healthcare? So we can either reflect on this example or just in general for people with long-term conditions. Doesn't necessarily have to be specific to children and young people with type 1 diabetes. But this is specifically in relation to providers of healthcare rather than commissioners or NHS England in general. Does anyone have any thoughts on that? Or if you don't, I can just jump ahead to the answer. I'll jump ahead then. So I've just added in some examples. That's really good. Actually, I haven't even included that here, Adele, so I'm very sorry for that. But maybe actually it's linked to my next point, which is going to appear. So ideally what healthcare providers want to be doing is providing early intervention and prevention, structured education and effective treatment, but making sure that these are adapted and tailored to meet the needs of the population. So really to do that, you need to engage with those who are using your service to understand what they need. And I've just got a very quick example here of a treatment that may actually, by not providing treatment for type 1 diabetes to those who need it most, you actually are inadvertently increasing inequalities and creating further inequity. The quality of these images aren't great. They're just a bit, the image quality of the report was poor that I stole them from. But basically what they show is that so the kind of best treatment really for type 1 is either, well, the best one is real-time continuous glucose monitoring, because it just reduces the onus on the individual to actually remember to take and kind of take their medication and make sure that they're getting the right level of insulin that they need. And then the next best really is an insulin pump. But since 2014, the percentage of children and young people living in the most deprived areas receiving insulin pump therapy has been consistently lower than those living in the most deprived areas. I said that wrong. So those receiving insulin pump therapy has been higher in least deprived areas compared to most deprived areas, and this gap has actually increased over time. So it was 7.9% in 2014-15 and increased to 11.5%. And similarly here, when it comes to CGM, those in the rate of usage is higher as well in the least deprived areas compared to the most. And evidence as well does demonstrate that by using CGM and insulin pumps over injections, you do have better HbA1c, better control and better outcomes. So I just thought that was kind of an interesting one to share. And this audit does really good inequalities related analysis, if anyone's interested. I did once work for the team, so I am kind of plugging them, but they're really good team of analysts. Cool. Any questions on that before I jump into measuring inequalities? Right, I'll jump ahead then.
Go for it.
Yeah. Right. Oh, Sandra's writing.
It's the little 3 dots of anticipation.
Yeah, totally agree. Having the right data can have such an impact, and having access to that is crucial. Cool. So, so measuring health inequalities. So this is basically just around analysing differences in health-related outcome variables to see if and how it varies for different groups of the population. I've included some examples here. Life expectancy, healthy life expectancy, mortality rates and risk factors and behaviours, and then also some condition specific outcomes. Does anyone have any other examples or would like to provide any specific examples of some of these outcomes that you may have analysed in your work?
Don't be shy, folks. Come on, it's the last session. Somebody's going to say something, surely.
I'll jump to the next slide. Oh, premature mortality. Oh, interesting. Do you want to tell us about what you did with your analysis of premature mortality, Simon?
Yeah,
You don't
well,
have to.
I saw you had mortality rates up there, and I thought, well, premature mortality rates, so you'd have to look at under 75s, as people shouldn't be dying that young, and you'd be comparing what areas have higher premature mortality rates.
Yeah.
Or a specific disease area. You can get the data for that too.
Thanks.
No worries.
Prevalence of disease, that's
Thanks,
another
Simon.
one.
Prevalence of disease, Nina says, and Aidan says years of life lost. I feel like that when I watch I'm a Celebrity.
I did go home last week and my mum had it on TV. And I was like,
Oof.
cool.
I think we should definitely move on now.
Well, so I'm just typing, but the next slide's related, so I'll just cover that. And then in terms of different groups of population, I've just included some examples of how we might commonly want to analyse differences. So we've got by individual characteristics, so age, sex and gender are really common ones that we typically use because we have data on it. In terms of wider determinants of health, like Public Health England and others do provide breakdowns of different indicators by education attainment, employment status, income, and also by location and deprivation. Deprivation is another one that's routinely available in the NHS for sure, maybe less so when it comes to local authorities and other settings. And also it can vary according to health service provision and treatment, which I hope we just demonstrated with the diabetes example. What I've included here on the right is an acronym from the World Health Organization of kind of the most commonly used equity stratifiers. So things that we don't generally have, I guess, in the NHS are around religion and other protected characteristics. I guess that there's just further sensitivity around collecting that data. Numbers are often small as well, so it's difficult to report on if we do ever get that data. Anyone want to comment on any of that?
Any takers?
Cool. I'm going to keep going then. One of, as I kind of already just mentioned, deprivation, and in England we specifically use the index of multiple deprivation. So I might just quickly do a quick 2 or 3 minutes maybe on the IMD and what it is. So it's a composite measure of deprivation, and it brings together information or actually kind of metrics across 7 different domains. So income, employment, education, health, crime, housing and other services, and living environment. And then basically there's a series of measures behind each of these indicators, which are combined to produce a weighted score to kind of generate an area-based measure of deprivation. So in England, that's at LSOA level, which is basically a geographical area. I think its origins are in like analysis of census, for census purposes and other statistical analysis reasons. But basically they're kind of small areas with a population, I think the average is around 1,500. So each of those areas, there's 32,844 of those, gets a score, and then those scores are ranked from highest to lowest. And then these LSOAs are ranked from most to least deprived. LSOAs map to different areas of population, and there's some of the, and LSOAs can also, the scores of LSOAs can be weighted to produce scores at CCG or place or whatever level now we're using these days, and also at local authority level. So that's how you can often kind of compare then outcomes in different CCGs with different levels of deprivation. And there's just some notes here as well on how it can and can't be used. So as I said, it's good for comparing across small areas. It's especially useful when trying to identify the most deprived areas. And you can compare across larger authorities. I've said that. Oh. Does anyone have any questions on IMD? I guess the last thing to know is just around when using it and describing it in any work or any outputs, because it's based on the level of deprivation in an area rather than the deprivation of a population of individuals. I will jump ahead. So just got some quick examples of different health inequalities. I've just used COVID here as an example. And here we've got mortality rates by deprivation. So the red shows mortality rates in the most deprived areas compared to the least deprived areas between January 2020 and January 2022. As you can see, it's consistently higher in each time period. This is as well as COVID related. On the left here, I've got vaccination rates by whether or not English is the first language of somebody. And what you can see here is that vaccination rates are higher for those for whom English is their main language. This could be down to like language communication, or it could be another factor like cultural factors as well. It could be kind of causing this, but you need to do further analysis to try and figure out what really the targeted or adapted method might be to try and address that inequality. I worked in North East London during the pandemic, and there was a massive effort really from the local authority and OCS working together with faith-based community groups and actually going out and trying to provide people with information and to kind of take more targeted strategies to try and address these differences. So I'm going to jump ahead. So
Can I?
Yeah.
Oh, that was quite interesting because in terms of what you said there, going out to faith-based communities and stuff, and I think, as I said before, the complexities of why somebody does some reaction is not really fully understood and analysed, I think, because a lot of, say, for instance, Black Caribbeans, they do have a lot of religious convictions, and so that's more deeply entrenched than, and also if that wasn't valued in the society, then coming to a faith-based community to tell them to do something which is against their religion, you're going to see the contradiction there, that they're not going to do it because there's no respect for that generally in the society, and therefore you then go into the same faith-based communities and expecting to convince the leaders to talk to the people, you're already up against a lot. So I think it's, as you say, it's extremely complex. And that's where the answers lie, really, the sources, and I'm sure other cultural groups can talk about their own. But I just know that I wanted to look at that in more depth, because that's one of the main reasons that I find in my area why people didn't take it up. And yet it was the answer was to go to the faith-based community to try and convince them. And I thought, well, it's like still saying that we got access, we're giving you access, and we see there's a demand and we have the supply, but and there's a need, but there's something missing in the whole cog, I think, if that makes sense, because those things seem to be ticked. So maybe you could help me to think on that, but
and that's why, like, I think it worked in Northeast London to a certain extent, because like lots of even just the staff employed in the CCG at the time were like, it's a really diverse area, really diverse workforce. And then working in the working really closely with the local authorities, who generally were working a lot closer with the different faith-based groups. By everybody kind of coming together, they were able to kind of address that need, and I think it increased definitely uptake rates to a certain extent, but I mean it still did reach a plateau at some point. But I still probably have some old colleagues working there. If you're interested, I can put you in touch with them.
yes,
I think my email will be on this, but I'll pop it in the chat anyway.
Thank you.
But yeah, it was a really interesting time to work there, and everybody worked really so hard. Like it was like, yeah, they beyond their hours. Yeah, it was to try and address it. But yeah, we've got Sandra's popped in the chat as well, that Leicester did interesting work to involve community leaders much more fully when take up issues emerge strongly. Yeah, it really is about engagement, and I hope that now, by working in ICSs or ICBs or whatever, that will get people working together and actually engaging with communities. Cool. Oh, Sandra's typing.
Just looking at the time, Lisa, I was wondering if maybe we should just carry on.
Will do. I kind of touched on this already, but kind of from a more analytical perspective. I don't know how many analysts we've got on the call. Does anybody have any particular methods or approaches that you're familiar with or have used in your work to measuring inequalities? Maybe I'll just jump ahead just in case, and I'll share the next slide, and then I might ask if anybody wants to share an example. So I stole this slide from, I think it was a presentation from NHS Scotland. It was added in the link, but I thought it quite nicely captures different types of measures. So if you're measuring the distribution of health in a population, you might look at different ranges, the Gini index, which is a measure of income inequality, I'm going to say, based on my best of my memory, but I think that's it. And lifespan variation, so how outcomes might vary over life expectancy. And then on the other hand, you have another examples of like estimating socioeconomic inequality in health. So you've got measures of association. So typically come from regression analysis, you would have an odds ratio, different regression coefficients, frequency ratios, absolute differences, so just the mean difference of values, correlation coefficients, so if you're looking at the association between two variables, or two or more variables, I should say, and the measure of potential impact. So this is more around population risk, and I don't know if anyone attended population health management courses, but they probably do a lot more around kind of risk and segmentation and that type of analysis. And then indices as well of ranking. So you could have a concentration index and slope and relative indices of inequality. So a concentration index, from memory, typically you would rank, let's say, your population according to income or socioeconomic status, and then rank them as well in terms of healthcare use, for example, and then look at the relative distribution of healthcare use according to income or socioeconomic status, and how that differs then from what you would expect if the population was, if the distribution was equal across the population. And then the slope and relative indices of inequality typically kind of capture the difference in the slope in an outcome between kind of the most or least deprived, from most to least deprived. So we saw that in the life expectancy earlier as well. Anyone have any examples of any work where they may have used any of these techniques, or would like, or have any questions about any of these? Sandra's typing.
I think
We
one of the
have
most
typing.
popular ways one of the most popular graphics we produced in Coventry when I was in public health there, the lifespan variation, doing it on a bus route and showing that in a small city, take one bus route that goes from sort of an affluent area to a poor area, and the difference in life expectancy or across that route. That was something that was used. Well, it was like probably our most used graphic for health inequalities.
That's a really, really cool example. Thanks for sharing.
I think we've actually got that in one of our projects for health inequalities across for COPD.
Ah, for star.
Yeah, I remember seeing the bus stop one across the different districts. So yeah, it is quite an impactful graphic, to be fair.
Yeah. It is, because you can really see the difference, like in life expectancy, just like with people living next door to each other, I imagine. It's just mad.
Yeah.
Shocking, really. Anyone else? Hannah, were you going to come in? Or was you just Hannah? Sorry. I thought I saw two people speaking.
Actually, I was going to kind of flag a problem, which is certainly I've worked in rural areas where you've got villages that have, you know, people of all levels of income and of all levels of advantage. And was it Marmot who talked about how, you know, the worst thing is to be poor in a rich area, because, you know, your needs will be glossed past because you just can't see them in the types of analysis we typically do.
Yeah, I think that's really valid, especially when you're looking at area-based deprivation as a metric. So as you can say, it can just mask those who have a healthcare need, and that's a limitation of using IMD for sure. But that's again where kind of this, if you can start engaging with communities more, and I think that's one of the intentions of ICBs. Hopefully you can try and address health inequalities and equity through that.
I would say.
Sorry, carry on, Sandra.
So I would say it's driving it the other way. Because
really?
where you've got strong geographic patterns, then the tendency is for them to take precedence over the populations that are more that are less easy to point to. And that is potentially a bit of a retrograde step. And I don't think we've got the tools to really do our best work for those people who live in, you know, they might be, for example, capital rich, big house, but cash poor, living in very difficult conditions and under the radar.
Yeah. Thank you.
I was just going to add, sorry, just agreeing with that point, that in many respects the core 20+5 approach doesn't help, because we've got, for instance, one district that has a similar thing. It's quite rural. It doesn't have any areas in the core 20. And so therefore all the funding is going to other areas, and it's very difficult to get any focus on that area, even though we know there's a lot of problems in rural communities. So yeah, I definitely agree with Sandra.
Yeah, I agree. It's really important. Thank you.
That's really interesting. I wonder, like, if there's, I guess, what strategy you probably would need kind of more, because those strategies are often set at national level, so you probably need some strong voiced person in there highlighting this need, and if that person's missing, then often things get missed, which is unfortunate. I'm going to move us on because we've only got a few more minutes left. I'm going to skip through this quite quickly. I guess these are the kind of generic steps that one might take when doing an analysis. So you would define your key questions, select relevant metrics, identify your data sources, do your analysis, do your reporting, and identify your priority areas. And these might be things that you need to focus on. Again, totally acknowledging that there are limitations in being able to do this, because often the data that we have doesn't allow us to do that effectively. I'm going to just do one quick example of some work that we did. So we produced a kind of cancer screening and outcomes dashboard for the Midlands Cancer Alliance. So like the key questions they were interested in answering was, how do screening rates vary in the Midlands? Are there differences at organisational level or by individual characteristics? And they were also interested in trying to understand what types of interventions might be available to increase screening uptake among kind of more hard to reach individuals. I've just got like some screen grabs, but what we did basically was created a dashboard which had screening rates, and we presented this by different characteristic or by organizational level. To the best of our ability, we tried to demonstrate differences in screening rates by characteristics, but the data just really wasn't there to do it effectively. And like they were really interested in trying to understand deprivation or change or screening rate differences in like those really harder to reach groups. So you might have like women in the LGBT community, for example, are less likely to take up screening for cervical cancer. So like by making a dashboard like this, you can't necessarily highlight those. But what it did do, the way it was used in the end, we kind of added in where we could other metrics like emergency care, admission rates, and we were able to break that down by different characteristics. And then by using the information in the dashboard, the idea was that the end user would be able to highlight where there were variations in screening rates or where their admissions were especially high by different characteristics. And then in this interventions tab, which I don't have a screen grab of, unfortunately, I didn't get a chance to drop it in, but basically we did a targeted review as well to try and identify published literature on like effective strategies for improving uptake. And we were able to categorize and break those down by like age, gender, deprivation, ethnicity, and any other factor really. And then the end user could go to this page and they could filter by the different things that they're interested in. And then it would generate examples of different techniques like targeted reminders and messaging to certain groups and all that kind of stuff. So it was, what we tried to do was highlight the inequalities and the differences and provide some evidence-based strategies as well that they could use locally to try and make a change. I'm going to, anyone have any kind of questions? I'll just quickly try and summarize the limitations really were available data and evidence. Reporting by small numbers was a massive issue because we had to mask like half the data if we wanted to look at like intersections between like age and ethnicity or gender. So that was like a massive challenge really when you're trying to produce something that like this was a big challenge really. And then as we kind of discussed earlier, kind of doesn't allow you to capture those really who would probably most benefit. But we hoped by adding in the interventions and the findings from the targeted review that would kind of still give people some information that would be useful in their role and their work. I can actually share a link to the dashboard and stuff. It's on NHS Futures. So I'll put that in the chat or in the slides, which you'll have afterwards. And like I did have 1 or 2 questions to finish off on around kind of what's the role of health and social care organisations and what's the role of NHS England, but we're kind of running out of time. But in the slides, I've included just some examples of what health and social care organisations might be doing and what NHS England are doing. And there's some more notes as well in the chat. But yeah, I'm going to stop now. But anyone want to say anything about anything before we finish up?
Now's your chance, folks, or you have to wait till March next year.
And I won't be here. I'll be on that one.
It feels like we've just set the context, doesn't it?
Yeah, yeah.
But it's good to hear about work where actually you're hitting all of those challenges and barriers and difficulties, because I think the more we try and grapple with the problems, the better the work that we do, isn't it? And sometimes it's a luxury to have the space. You know, those difficulties sort of lead you to put that analysis to one side, rather than, you know, really bringing to light the problems and the challenges with achieving improved equalities.
Yeah, definitely. And like data is a big factor, but data alone can't solve the problem. And I think that's a message that often gets lost, I think, and people keep focusing on trying to get stuff out of data. But if you're not doing the right analysis, or if you're just looking too broadly at things, you're not going to address the problems really.
Mm-hmm.
And we're going to continue on this path. Sorry, I'm going to go all the way back here. We're going to just stay like this, and we're not going to keep improving. Yeah. And these numbers aren't going to change, which is shocking, but hopefully they will. There's a really passionate group of clinicians and others who are trying to change this. So yeah.
Thank you for a great session. And for me, it's looking at this data, and also with my work that I'm doing here, I've realised that I've really got to look at the inaccuracies in data capture, really, even just on protected characteristics. It's just not there. And in our last health equity audit, it brought that up, but it still wasn't, we just didn't know how to address that. So I think that if there's anything you can point me to or direct me to learn a bit more about how to just capture that more, because I think some of the data that we produce can be quite, for want of a better word, skewed. It's usable, but it's because we don't capture who's coming through the door very well. We don't understand their needs. We just sort of encapsulate them into not known. And the not known is, well, what do we do with that? And it can be quite a lot of people in that category. So it's made me think about that even more, to be honest.
And that unknown category is increasing as well. I think people are becoming more reluctant to self-report their actual characteristics, which is frustrating from an analytical perspective and a service planning perspective. But if you have questions, I'll share my email address and shoot them over.
Yes, please. Yes,
yeah.
please. Yeah. Thank you.
I've added a feedback form link in the chat for everybody. Just bear in mind it is the last session, so a 5 out of 5 rating would be really good. But please leave some honest feedback. We welcome all sorts so that we can improve these sessions. I just like to say I haven't been in this from the start. I only joined the HEU a few weeks ago, but thank you very much for the participation. It's been really good. It really helps make the sessions really pop. So round of applause for all of you guys, and thanks for joining us.
Yes, definitely. I would like to second that. It makes it so much easier when people are engaged. So thank you guys.
And don't forget the feedback form. Thank you. If nobody has any more questions, oh, Aidan's just typing something. Right, you know, great. No, all the thanks can keep on coming. I shall bask in the glory later.
I just put my email address in the chat.
Even though I've not done anything, it's all Lisa. On that note, I shall.
Just one last question. Do you think this session should be probably 2 2-hour sessions? It was too much. Would you people a thumbs up if you agree that it was too much to do in 2 hours and we only scratched the surface of things really? Just for future planning.
I would want to do it at this pace, but you know, cover the material at this pace, but have a bit more time for those discussions and maybe be able to take it on to the next level in terms of maybe some more going through some more examples and thinking about applicability to practice rather than slowing it down. I'm greedy and I just, you know, I always want more. So.
That's brilliant. Do pop that in the feedback forms as well, because then Phil and the team will give us evidence to make the change we need to make really for the upcoming sessions.
Brilliant. On that note, folks, I'm going to end the recording and I'll just final word. Thank you again very much. It's been great having you all here, and thanks, Lisa.
Yes, thank you very much. Thank you. I know.